Hello, good afternoon, everyone. Welcome to today's webinar addressing the use of long-acting reversible contraception, or LARC, with special considerations for use with young women and women with heavy menstrual bleeding. My name is Dr. Claudia Borzutzky. I'm a clinical associate professor of pediatrics at Keck School of Medicine at USC, and I'm the program director for our adolescent medicine fellowship here at Children's Hospital Los Angeles. One of my clinical interests in using LARC is in using LARC for the treatment of heavy menstrual bleeding, particularly in adolescents, and I will be moderating today's webinar. Next slide, please. So about the Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Next slide, please. Since its inception, the Foundation has focused on realizing its vision through these objectives, which you can see here. And just for the sake of time, we're going to move through these slides quickly, but you can see that the objectives of the Foundation are around building awareness, providing education and training, encouraging collaboration, promoting best practices, translating and disseminating research, and educating the next generation of healthcare providers. So next slide, please. These are the members of our board. We have a renowned and engaged board with deep expertise in treating women and girls with blood disorders, as you can see here. Next slide. And then a little bit about the LAN. The Women and Girls with Blood Disorders Learning Action Network is a national network for healthcare providers dedicated to the care of women and girls with bleeding and other blood disorders. The LAN focuses on bringing people together to optimize clinical care, generate new knowledge, and to share knowledge with one another in the larger hematology and women's reproductive health community. We are all LAN members who are going to be presenting today and collaborate frequently in addition to conducting collaborative research together. Next slide. So for today's activity, the medical director for this webinar is Dr. Andrew James from Duke University. The planning committee for today's presentation includes Dr. Barbara Conkle from the University of Washington and James Munn from the University of Michigan. Next slide, please. In support of improving patient care, this activity has been planned and implemented by Cinemed and the Foundation for Women and Girls with Blood Disorders. CME will be provided to physicians and nurses, and a follow-up email will be sent to attendees explaining how to obtain CME and CE credits after the webinar. This activity is offered through Cinemed's continuing education program, which has been accredited for offering one AMA PRA Category 1 credit for physicians and 1 contact hour for nursing professionals. Next slide. In order to claim your credits, complete the pre- and post-test questions, please, online through the survey from the FWGBD, and a certificate will be emailed. The link will be provided to you in a follow-up email that will be sent automatically from the GoToWebinar. And this activity we would like to acknowledge is being supported by an educational grant from Bayer Pharmaceuticals. In accordance with Cinemed's continuing education policy, the Faculty and Planning Committee for today's webinar have disclosed any significant financial interests or other relationships of interest relative to the topics that will be discussed during this program. Such disclosures allow you to better evaluate the objectivity of the information presented in the lecture, and you may learn more about this at the Foundation's website at fwgbd.org. Next slide. So just some housekeeping. To ensure the best sound quality during the webinar, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with the faculty at the end of the webinar. You can submit your questions during or after the presentation portion of the webinar via the chat box in your GoToWebinar control panel on the right-hand side of your screen, and we will address them during the Q&A session at the end of today's presentation. Next slide. So about our faculty today, today's presenters are Dr. Oluyemisi Adeyemi-Fowode from the Department of Obstetrics and Gynecology. Yemi, I hope I pronounced your full name correctly, Division of Pediatric and Adolescent Gynecology at Baylor College of Medicine, and Dr. Allison Wheeler, Assistant Professor from the Department of Pathology and Associate Medical Director, Transfusion Medicine and Coagulation in the Department of Pathology, Microbiology, and Immunology at Vanderbilt University Medical Center. Next slide. So learning objectives. Here are our learning objectives for today. At the end of this activity, we hope learners will be able to explain the importance of and apply to practice assessing and monitoring patients for the identification of appropriate patients for intrauterine contraception, to describe the proper placement of intrauterine contraception, to discuss the effectiveness and safety of intrauterine contraception in young women and women, especially those who are at risk for or experience heavy menstrual bleeding, to review the anticipatory guidance needed prior to initiation of the method, to discuss best practices regarding pre-medication, insertion, and post-procedure for the levonorgestrel intrauterine system, and to discuss ways in which collaboration with hematology augments management. For those who wish to refer to these objectives later, we are recording the program and it will be archived on our website. Next slide, please. So before we begin, we'd just like to do a quick poll to see how many people are joining us today with others. Please take a moment to answer the poll questions on your screen for how many people are with you. And let's see, and you can select one of these answers. And please let me know in the chat if you are unable to do the poll answers. All right. How are we doing? We'll give it a couple more seconds. All right. Thank you, everybody. And I'm going to hand it over to our presenters.
Okay. Hi, everyone. I'm Allison Wheeler. So really quickly, we're just going to go over what our group considers to be a pretty classic case for a young woman who's presenting with heavy menstrual bleeding who we might see in our clinics. So this patient is a 16-year-old who came to the hematology clinic. She has a history of 10 days of which she considers to be heavy menstrual bleeding that's been worsening over multiple days. She's actually been bleeding for about 16 days now and is currently saturating a pad an hour, and that's been going on for about the last day with breakthrough bleeding overnight, large clots, and a hemoglobin on presentation of 8.2. When we look at her menstrual history, let's see. There we go. When we look at her menstrual history, she started menarche 3 years ago, has relatively regular cycles with very rarely missed menstrual periods, and predominantly states that her bleeding is heavy. She otherwise has no medical concerns, including no other bleeding history, although also no surgical procedures, and she has no family history that contains diagnosed bleeding disorders, but mom does have heavy menstrual bleeding and prolonged postpartum bleeding. If we want to look at her labs, we can see them here. She did come to a hematology clinic, so that's a little bit more aggressive on that side, but her CBC is pretty much as mentioned. She does have some iron deficiency. Her TSH is normal, and as you can see, her coag testing is predominantly normal or elevated values, and so we're going to talk a little bit about what that means as we go through, but we thought this was a nice classic presentation that really requires some collaborative considerations between both gynecology and adolescent medicine, as well as hematology. And we're not going to go over this slide specifically because as Yemi and I go through the next couple of slides and how we think about these patients, we're going to touch on all of these points. So I'm going to hand it over to Yemi now and let her take over.
Thank you, Allison, and good afternoon, everyone. Thanks for joining us. Here are the parameters for normal menses as described by the American College of Obstetricians and Gynecologists, or ACOG. We know that menses can be erratic in the initial first 2 to 3 years of attaining menarche, but typically the interval should fall within 3 to 6 weeks and last a week or less. Menstrual product use differs per individual, but having to use more due to soilage and not because of hygiene can definitely be a red flag. Abnormal uterine bleeding, or AUB, is defined as bleeding from the uterine corpus that is abnormal in volume, regularity, frequency, or duration. And historically, heavy menstrual bleeding, or HMB, has been defined as blood loss that's greater than 80 cc's, but this is not a good practical way to measure it. And so the definition has become more centered around what a patient's perception and lived experience is, rather than just having a rigid criteria. It is now defined as excessive menstrual blood loss that interferes with a woman's physical, social, emotional quality of life. So here are the causes of abnormal uterine bleeding. They are multifactorial, and a classification system with a standardized terminology was introduced back in 2011. So terms like menorrhagia, which I learned in medical school, is now outdated, which I'm completely okay with because documenting and spelling menorrhagia took way more time than necessary anyways. So we have this new PALM-COEIN system, which designates causes of AUB into 2 main categories. PALM, which refers to the structural causes like polyps or fibroids, and COEIN, which refers to non-structural causes. This is where majority of our adolescents will fall, with ovulatory dysfunction and coagulopathy being the most common etiology in this population. ACOG also has guidelines in place for when to consider evaluation of menstrual abnormalities in the adolescent. I want to direct your attention to the bottom half, which highlights menses that occur more frequently than 21 days, last more than 7 days, require more frequent use of sanitary products, is heavy, and associated with a history of excessive bruising or bleeding. This should raise a red flag. Heavy menses with a family history of bleeding disorder is also concerning. Allison will discuss the evaluation for HMB in detail. However, I wanted to briefly mention some additional considerations. So pregnancy should be ruled out as a cause regardless of reported sexual history. Any reproductive age woman with this complaint requires a pregnancy test. Evaluation for sexually transmitted infections or STIs such as chlamydia should be performed if it's indicated. Endometrial biopsy to evaluate for malignancy is typically not indicated in adolescents except in special circumstances. As I mentioned earlier, structural causes like polyps and fibroids are rare, so really getting a pelvic ultrasound should be left to the discretion of the clinician. And lastly, I just wanted to point out that in the case of active or ongoing bleeding, a pelvic exam should be performed, but that does not need to involve a speculum exam. Taking a look at the external genitalia will suffice and help make sure that the bleeding is not coming from another area of the genital tract, such as a hymenal tear. This figure here to your right basically demonstrates the technique of labial retraction by using the thumb in a down and out manner to allow for a clear view of the hymen in the introitus. And in some cases, you can even see the distal 1/3 of the vagina. Back to you, Allison.
Okay, so I can't remember the last vaginal exam I did, but I do spend a lot of time thinking about exams for bleeding. So when you think about bleeding disorders and who we should test for bleeding disorders and how girls who present with heavy menstrual bleeding should be considered for bleeding disorders, we can think about it from the perspective of somebody who has a bleeding disorder. So in that case, about 75 to 80% of those girls are going to present with heavy menstrual bleeding or have heavy menstrual bleeding as a common clinical manifestation of their disorder. And about 50% of those are going to have bleeding from the time of menarche. So they're going to come in and say, ever since I started my period, it was heavy. From another perspective, you can think about what percentage of women or girls with heavy menstrual bleeding have bleeding disorders. And depending on how you do your research or how you look at that population, it comes out to about 20 to 40%. And you can see a really nice table on the right side here looking at diagnoses of women who presented with heavy menstrual bleeding, coming in and ending up with a diagnosis of von Willebrand disease, clotting factor deficiencies, platelet disorders, more rare bleeding disorders like PI1 deficiency, or in the end, no definable bleeding disorder. So how do we want to think about these patients when they come to us? We want to sort of recognize them as people who have a bleeding tendency, and then really dig into their personal or family history, as well as obtain a bleeding score to sort of try to quantify their bleeding history a little bit, and also look at a physical exam for any signs or symptoms of increased bleeding, like abnormal bruising locations, petechiae, or aggressive epistaxis. Here's an example of a brief bleeding assessment tool, similar to the ISTH bleeding assessment tool. And this is just a really nice way of sort of trying to say, does my patient have this increased propensity for bleeding? Now, a positive bleeding score in children is 2, so it really doesn't take very many bleeding episodes to end up having a positive score as a child. For adult men, it's a score of 5, and for adult women, it's a score of 6. And our adolescent females are going to fall somewhere in between there because they do have their periods and we need to consider that, but they also probably haven't had many other bleeding challenges. So this is just a nice way to sort of help you think about these women a little bit more quantitatively. When we do want to perform a full bleeding evaluation, this is a nice place to start. So a full blood count, liver and kidney function testing, as well as a platelet function screen. So here at my institution, we use the PFA 100 for this. There are limitations and difficulties with the PFA 100, but it's a nice way to sort of ask a question, how are these patients' platelets functioning? Performing a full von Willebrand assessment, and we'll get more into what that means in the next slide, and then also an assessment of plasma coagulation. So the reference on this slide is actually a really lovely one, and it can walk you through all the details and sort of how to think about a bleeding evaluation or a hemostatic evaluation in these patients. But just to talk very briefly about some initial thoughts. Primary hemostasis, I prefer to describe as formation of a platelet plug, allows you, what you need to assess to understand that part of hemostasis is a platelet function assessment. So the PFA 100 is a nice way to sort of say, is there a platelet function abnormality? But really, going to platelet aggregation testing is going to be able to define more specifically what that platelet function abnormality is. Both of these tests have limitations, including medication effect, clinical variability seen in patients, as well as just the difficulty of working with platelets in and of themselves. Platelet aggregometry can be abnormal because people exercise too much even. And there are other tests that you can do, like platelet flow cytometry and things like that, but we're just not going to, we don't have the time to go into that today. Von Willebrand assessments are also quite complicated. They can be affected by blood type. People with blood type O have lower von Willebrand factor than other people with other blood types. This protein increases because of acute inflammation, as well as physiologic variation, like at times when estrogen is higher physiologically in the body. This is a lovely diagnostic algorithm that is in the New England Journal paper reference here, which is a lovely review article of von Willebrand disease, if anybody's interested in digging into that. Thinking a little bit more about secondary hemostasis, I do just want to touch base on the fact that hematologic testing should occur in a lab that can do really good esoteric testing. I'm always considering a mixing study first to look for inhibitors versus deficiencies, and then consideration of either clinically significant or non-significant, non-specific inhibitors, and then being able to assess factor activities as well as look for nuances in fibrinogen abnormalities as well. So definitely being able to work close with your coag lab is going to be very helpful here. And then finally, just remembering that even if all of these tests are normal, there are other hemostatic challenges that we do need to think about: vascular hemostasis, hyperfibrinolysis, factor 13 deficiency. And I definitely have a cohort of patients in my clinic who all of their laboratory testing down to the most esoteric lab I can consider is totally normal, but they do bleed. and I treat them like they have bleeding disorders and call them bleeding disorder NOS. And so I do love this little purple box, which is words from one of my mentors, Dave Galani, which is just remembering that the most reliable indicator of whether or not a patient has a bleeding disorder is their clinical course. And then finally, why do we talk about this and think about hemostasis so much in heavy menstrual bleeding? Well, you know, the development of our endometrial lining, or the woman's endometrial lining, and then the shedding of that is obviously what causes menses, but we are disrupting blood vessels here, and we do require normal blood vessel repair and hemostatic support to cease that bleeding. And so an intact coagulation pathway is really important, and that's why so many women will present with heavy menstrual bleeding when they have a coagulation abnormality. There are a number of therapeutic considerations that can be used to treat these women, and we're obviously not going to talk about all of these today, but just to sort of make note of the fact that many of them can be successful in both women with and without bleeding disorders. But with that being said, we're going to transition to the IUD now, and I'm going to let it go back to Yemi so that she can talk to you guys about that in more detail.
Thank you again, Allison. And so here we are, we're back at our presentation, and you've counseled her about all the available hormonal options, and she is interested in the IUD, but has some questions. I imagine that these questions regarding eligibility, bleeding, infection, and fertility sound very familiar to folks that counsel teens regarding the IUDs. So here are some interesting facts about the IUD. The first documentation of this idea for humans was back in 1909 when Dr. Richter, a Polish gynecologist, reported on his insertion of a ring made of silkworm gut into the uterus. As you can see from this figure on the left, many modifications happened afterwards with variable success, and reports of adverse effects like bleeding, cramps, and high pregnancy rates. The 1960s to 70s brought about the development of the copper IUD, and in the 1970s, Dr. Antonio Scomegna introduced Progestastat, and this was the first progesterone-releasing IUD in the US. This IUD had a short lifespan. The progestin was short, and it was replaced by the longer-lasting levonorgestrel progestin. And so in 1984, the copper IUD became approved, and in 2000, the Mirena was approved by the FDA. The history of the IUD has been tumultuous, and as I mentioned on the previous slide, there were reports of various complaints for women. But prior to the Dalkon Shield, infection rates had been highly ignored. In 1971, the Dalkon Shield was released, and as you can see here, it's kind of this scary looking thing, almost like a plastic crab or fish with claw-like appendages that was designed to resist expulsion, and a braided string that resembles a tampon string. It was aggressively marketed but caused an array of severe injuries, ranging from pelvic inflammatory disease or PID to perforation, infertility, sepsis, and even death. Many users sued the company, and 3 years after it was released, the FDA suspended the sale of the Dalkon Shields. As you can imagine, after the dangers of the Dalkon Shield became public because of this lawsuit, the popularity for IUDs decreased significantly in the US because women became distrusting of its safety. There are currently 5 IUDs that are available and marketed in the US. The non-hormonal copper IUD, Paragard, and then 4 hormonal levonorgestrel releasing IUDs. All the hormonal IUDs are made by Bayer, with the exception of Liletta, which is actually very similar to the Mirena. IUDs vary slightly in their size and in the width, and are all very effective as contraception, with basically less than 1% risk of pregnancy. And so the biggest difference would be in the dosage of the levonorgestrel, which affects the daily systemic exposure and also the amenorrhea rate. The Mirena is the only one that's approved for heavy menstrual bleeding in addition to contraception. Here, the precise mechanism of action for the IUDs remain unclear, and it's likely due to a combination of things. So thickening of the cervical mucus, endometrial changes that are spermicidal and inhibit sperm migration through the endometrium, and the progestin also causes atrophy or thinning of the endometrial glands. This is the original FDA labeling for Mirena. And so note that there have been a couple of changes, as evidenced by new labeling that was released, just 2 months ago. The length of use as contraception has been extended from 5 to 6 years due to data showing it continues to be efficacious for contraception past 5 years. As I mentioned a couple of slides ago, the Mirena is the only IUD indicated for treatment of HMB. The new labeling has not extended its length of use for that indication, and that's still 5 years. I was also very pleased to note that the IUD has removed the recommendation that only Paris women should have it placed. Besides contraception, the Mirena can also, be used for treatment of HMB, dysmenorrhea, endometriosis, endometrial hyperplasia, and is a very effective tool for suppression of menses. History has negatively impacted the use of IUDs in all women, but especially in the adolescent and young adults. There are a lot of myths and misconceptions, some of which the patient in our case presentation asked. And the reality is that this adolescents and their parents just don't have enough information. And we as the providers are the arbiters of IUD use in adolescents. And so, our attitude or biases towards the IUD matters. And a lot of times clinicians will often cite, being concerned about infections or difficulty with insertion, thinking that the woman should have at least had a vaginal delivery to be eligible. In 2013, there was a survey of pediatricians, and it revealed that fewer than 20% would discuss the IUD as an option for adolescents. And my people, the OBGYNs, did not do too great either. In 2014, there was a survey of OBGYNs, and only 43% of us considered adolescents as good candidates for the IUD. This leads to basically a lack of awareness among our teens and young adults. And it's reflected in the data because it's been reported that 2.5% of adolescents were using the IUD in 2010 compared to 2.8% in 2015. So this isn't really a big jump. Other barriers would include access to IUD, the cost. Teens are typically under their parents' coverage and sometimes would worry about confidentiality with those explanation of benefits. Those that get brave and ask about it may be met with reduced availability, and that can occur if the provider or the clinic offers restriction on the age of those offered care, or with religious health system mergers, sometimes that limits providers to placing IUDs only for non-contraceptive benefits. Culturally, we still have that belief that the use of contraceptives might lead to sexual promiscuity, and so we have a lot of work to do in this area. Daily or weekly medication can be challenging for adolescents, and so it's not the ideal choice. In the case of bleeding disorder, you can have dire consequences like hemorrhagic shock, and the need for transfusions might arise if treatment is not taken as instructed and bleeding ensues. And so long-acting reversible contraceptives, or LARCs, refers to those methods of contraception that are effective for an extended period of time and do not require user action. Specifically, the contraceptive implant, Nexplanon, and IUDs. When we compare LARCs to short-acting options, they do have a higher continuation and satisfaction rate. And over time, there's been a push to increase LARC awareness with our governing bodies like ACOG and the American Academy of Pediatrics, or AAP, releasing encouraging statements regarding IUD use in this population. So, prior to placement, you want to get a thorough history that would include any known medical problems or other special conditions that should be taken into consideration to determine if the patient is an appropriate candidate for IUD. Providers should be reasonably certain that the patient is not pregnant, and then effective counseling and informed consent should be obtained. Method-specific counseling is highly encouraged, and I'll go through this in a bit more detail in upcoming slides. Among healthy women, few examinations or tests are needed before initiating an IUD. In this figure here to your left, A basically corresponds to essential and mandatory exam or tests, and C refers to those that do not contribute substantially to the safe or effective use of the contraceptive method. So thankfully, we don't need much for an IUD placement. A bimanual exam and cervical inspection will be necessary before an IUD is inserted. And if a woman has not been screened for STDs according to guidelines, that should be performed. So the United States Medical Eligibility Criteria for Contraceptive Use, or USMEC, is a document for the CDC which provides recommendations on the safe use of contraceptive methods for women with various medical conditions. This document provides eligibility categories with 1, demonstrating no restrictions for use, all the way up to 4, which basically represents an unacceptable health risk if the method is used. There is also a free app available for mobile devices. So as you can imagine, this document is really long. I mean, they include conditions from cystic fibrosis to malaria. And so what I try to do here was just point out specific conditions where the Mirena is contraindicated, and I have indicated those in red. The green corresponds to category 2, where benefits outweigh risk. So if we look at this list here, the big no-nos would be any sort of active infection, if you have a uterine anomaly, current breast, cervical, or endometrial cancer, and pregnancy. I do want to point out that vaginitis from bacterial vaginosis is not a contraindication, and we don't typically test for this in the asymptomatic woman. Again, chlamydia or gonorrhea, which can cause PID, should be tested for according to guidelines. So contraception counseling for adolescents is a complex topic, and it's often more challenging than in an adult. The teens are more susceptible to information overload. You add this to whatever their maturity level is, the process of puberty and development, and I think that we would all agree that simplification is key. And so this braided approach is an acronym that highlights information that should be provided to allow an individual to make a well-informed decision. It stands for benefits, risks, alternatives, addressing inquiries, expressing to the patient that they can withdraw from use, it's their right, explaining the method, and then documenting the interaction. It basically summarizes the principles for effective counseling within a developmental framework. Age or nulliparity is not a contraindication to IUD use. The MEC classifies its use in a nulliparous woman at a 2, so benefits outweigh risk, and for parous women, it is classified as a 1. So the exact wording that they use to describe why, I'm going to quote that. So I quote, "Data conflict about whether IUD use is associated with infertility among nulliparous women, although well-conducted studies suggest no increased risk," end quote. So what I take away from it is that it means we just don't have enough data in this population. However, available literature, including systematic reviews, demonstrates that nulliparous patients are not at an increased risk for failure, expulsion, perforation, pregnancy, pelvic infections, or infertility. And so that being said, there are some considerations to take into account regarding this patient, one of which would be the pace at which the examination is conducted. Majority of adolescents have never had a speculum exam, and some never do until they turn 21 when they are screened with a pap smear. And so providers should inquire about prior experience regarding speculum exams. We're now going to play a short video about how to appropriately place a Mirena IUD. This video is from Bayer Pharmaceuticals website.
Insertion. First, open the sterile package completely. Then use sterile technique and sterile gloves. Mirena is provided within an inserter consisting of the Mirena itself, already in the correct horizontal position, an anatomically curved insertion tube with a double-sided centimeter scale and a plunger inside, the flange, and the handle containing the mark, the slider, and the threads inside. Push the slider forward in the direction of the arrow to the furthest position to load Mirena into the insertion tube. Do not pull the slider downwards, as this may prematurely release Mirena. Once released, Mirena cannot be reloaded. Holding the slider in the furthest position, set the upper edge of the flange to correspond to the sound measurement of the uterine depth. While holding the slider in the furthest position, advance the inserter through the cervix until the flange is approximately 1.5 to 2 centimeters from the uterine cervix. Do not force the inserter. Dilate the cervical canal if necessary. While holding the inserter steady, pull the slider to the mark to open the horizontal arms of Mirena. Wait 5 to 10 seconds for the horizontal arms to open completely. Advance the inserter gently towards the fundus of the uterus until the flange touches the cervix. Mirena position. All the way down. While holding the slider all the way down, gently remove the inserter by pulling it out. Cut the threads to leave about 2 to 3 centimeters visible outside of the cervix. Mirena insertion is now completed.
And so, while there are no differences in the outcome based on parity, nulliparous has been associated with greater pain and fear of pain. One should consider the use of a smaller or narrower speculum, such as a Pedersen, as opposed to the wider Graves speculum, to try and decrease discomfort at speculum insertion. A Cochrane review looking at interventions for pain during IUD insertion concluded that NSAIDs did not necessarily help to reduce pain at insertion, but may be useful if cramping is experienced later. Evidence supports the use of paracervical block and should be considered. Making sure to maintain a gentle, even tone and explaining the process step by step is preferred. Patient can get very jumpy if they don't know what to expect, though I've noticed this is definitely not true across the board. Some of my teens request putting their headphones in and listening to soothing music, so I always ask what their preference is. These interventions can help make the process less traumatic and also prevent vasovagal reactions. After placement, it's important to reiterate post-insertion instructions, such as using backup protection if indicated, encouraging use of pain medication for about a day or so if it's necessary, a reminder not to put anything in the vagina for at least 24 hours. Bleeding and spotting are common for the first few days to months, and they should be encouraged to chart it. Reaching inside the vagina to feel the strings can help reassure some that the IUD is still in place. The majority of adolescents will not be comfortable with this, and so it is optional. And then lastly, instructions of when to call the office with fever, purulent discharge, pain, and so on is also helpful. Typically, no routine follow-up is necessary, and that's really one of the many benefits, of the LARCs. Now, at other visits, a provider should assess for concerns and changes in health status and consider checking for a strain. That's for more mature women. The adolescents need more frequent follow-ups, and at least that's appropriate initially. I typically will have them return in 3 months to address any concerns, make sure they're still happy with their choice, and then a string check during that visit is typically not necessary, but can be performed if there's a concern and if the patient can tolerate it. A single-digit finger exam can be used in place of a speculum at times. So, the Mirena has been demonstrated to reduce menstrual bleeding in all women, and with the reduction ranging from 74 to 97%. And this in turn helps to increase hemoglobin and iron levels. It has been compared to other medical therapies and found to be superior. And so randomized clinical trials have compared it to OCPs, oral progestins, and have all reached the same conclusion. It's also been compared with Lystata and found to be more effective. And so it certainly can be used as a first-line treatment for heavy menstrual bleeding. The bleeding pattern varies per individual, but the expected menstrual bleeding pattern is a trend towards lighter and less frequent bleeding. Unscheduled irregular bleeding occurs most frequently in the first 3 to 6 months, but the amenorrhea rate is around 20 to 50% within the first 2 years and increases to 60% by year 5. So a lot of people are happy to hear that. It should be noted that amenorrhea rates for the levonorgestrel IUD are highest with the Mirena, as opposed to other types that have lower total and daily dosage of hormone. So data from the CHOICE project revealed high satisfaction rate of about 85% among Mirena users. The CHOICE project was an observational cohort study developed to promote the use of LARC methods in the St. Louis area, and they enrolled over 9,000 women ages 14 to 45. When you break the result down into the youngest age group of 14 to 19 years old, the satisfaction rate was still high at about 78%. Similar results were noted from a prospective study of students ages 18 to 30 that were enrolled in a student health clinic. All of this translates to high continuation rate. And as you can see from this figure, taken from a systematic review, looking at the continuation rate of various contraceptive methods in adolescents and young women, the ages were 25 years and under, and they looked at it after 1 year of using a particular method. This review looked at studies as far back as 1975, when some of these methods were not even available, all the way to 2015. And so the findings suggest that LARC continuation use, and more specifically, the IUD continuation rate was the highest among all contraceptive types. IUD use in adolescents have very low rates of complications, such as PID or uterine perforation. The association between IUD use and infertility has also been debunked. A subset of women in the CHOICE study were looked at, and they revealed no difference in their 12-month pregnancy rate or time to pregnancy. The highest risk of infection actually occurs within the first 20 days or 3 weeks of placement, and beyond that, IUDs do not increase the rates of PID. And so the risk is about 0 to 2% when no cervical infection is present, and increases up to about 5% when there is an infection, which is why it's important to screen our sexually active adolescents. Counseling about adverse effects is important, with the most common being changes in menstrual bleeding patterns, which we already discussed. Progesterone-related hormone effects like breast tenderness, mood changes, acne, and headaches may also occur. Pelvic pain is a possibility, especially if the IUD becomes malpositioned, and that can certainly lead to an increase in expulsion. Ovulation may still occur, and ovarian cysts may be noted. And with that, I am going to turn the remainder of the talk over to Allison.
Okay, I think I just advanced that slide appropriately. So going back a little bit to our patients who have bleeding disorders and whether or not our IUDs are the same, or concerns with the IUDs are the same or different for those patients. There's a couple of points that we want to just go over. One is the potential risk for bleeding at the time of insertion because of the procedure itself. The second one is whether or not these patients have increased uterine bleeding after the IUD is placed, whether they have persistent or recurrent heavy menstrual bleeding. Do these patients have an increased risk of expulsion? And do these patients have an increased risk with ovarian cysts? So there hasn't been an enormous amount of research that's been done looking specifically at the bleeding disorder population, but there have been a few well-done single institution studies. So looking at the potential risk of bleeding with insertion, Chi et al. Studied actually 153 adolescents with bleeding disorders who were receiving some sort of hormonal treatment. Now, only 5 of those patients had IUDs placed, and all of them received some form of hemostatic prophylaxis. 2 of them getting their IUDs placed under general anesthesia, and 3 in the clinic setting. And there were no bleeding complications with insertion in that patient group. Dr. Adeyemi, my co-presenter, looked at her group and saw 13 adolescents with bleeding disorders and IUD placements. Again, all of whom received hemostatic prophylaxis and all of whom had their IUDs placed under general anesthesia with no bleeding insertion complications. So both of these groups represent institutions where there was great collaboration between the gynecology groups as well as the hematologist, and they had co-management to place the IUDs, and they both took a really conservative approach. Dr. Adeyemi, myself, and Dr. Borzutzky are a part of a research group that are trying to understand IUD insertion and use in women with bleeding disorders in a little bit more detail. And our group has started off by doing a provider survey. And just to sort of speak a little bit to our results, the most accurate thing that I can tell you is that there's a lot of variability in how people place IUDs, whether or not they're placed with hemostatic management, whether or not they're placed under general anesthesia or in the clinic setting or in the clinic setting with sedation. So there's a lot of variability in practice in this regard. And so understanding what the optimal treatment options are for these patients is still up in the air, I would say. But as you can see from these studies, we can do this safely, especially if we have co-management between different subspecialty groups. Transitioning to persistent or recurrent heavy menstrual bleeding, again, there have been a number of groups that have looked at this. So Shandell et al. Studied 28 women with hemostatic disorders after IUD placement, and almost 70% of those women experienced improvement in their bleeding. Dr. Adeyemi's article that I referenced in the last slide also demonstrated improvement. It took about 3 months, but about 60% of those women became amenorrheic and demonstrated both hemoglobin and ferritin increases. So I really loved that this study, as well as the next one by Kingman et al., talked about the duration of time that it took for women to see an improvement in bleeding symptoms, because we're definitely going to experience some irregular bleeding with a progesterone-only hormonal method to control heavy menstrual bleeding. So this expectation that there be potentially 3 months, potentially more than 3 months of time before we can see optimal improvement in the heavy menstrual bleeding is really important when we're counseling our patients, and also really important when we're considering how to treat their persistent bleeding or their persistent heavy menstrual bleeding after IUDs are placed. Again, this is an area where we could definitely use more information, but these are just some initial thoughts. Transitioning to expulsion, this is definitely a theoretical concern within the bleeding disorder population. Expulsion happens in about 2 to 10% of women who have IUDs placed, and typically expulsion can be associated with heavy menstrual flow or increased clotting, which is definitely something we worry about in the bleeding disorder population. So looking at the studies that have identified expulsion rates, Rimmer et al. Was actually the first group to look at this. This is out of Canada, and what they showed was that there was actually a higher expulsion rate in the bleeding disorder population, 15% with expulsion, and that percentage increases to 25% when you include malpositioning in that as well. Dr. Chi showed an 8% expulsion rate, and Dr. Adeyemi showed almost an 8% expulsion rate. So really at the higher end of the anticipated range of normal healthy people. So again, something that we need to learn more about, and something that we need to consider when we're counseling our patients and they're thinking about getting IUDs. And then finally, there's the concern about ovarian cysts. And I use the word concern really specifically for this slide. So studies actually do show that there is an increase in ovarian cysts among women who use IUDs, so 21.5% versus 8% in women who don't. Now, 94% of these ovarian cysts are going to spontaneously resolve in 6 months, but we can sort of extrapolate that into another theoretical concern of the increase in hemorrhagic ovarian cysts that we see in women with bleeding disorders. So the CDC did a study that demonstrated that there was an increase in hemorrhagic ovarian cysts in women with bleeding disorders. So you sort of put these two bullets together, and we could worry about an increase in hemorrhagic ovarian cysts among our bleeding disorder patients who have IUDs placed. So again, not something to keep us from putting IUDs in women with bleeding disorders to help control their heavy menstrual bleeding, but something to consider when they present with signs and symptoms that may be concerning for ovarian cysts or hemorrhagic ovarian cysts, and also something to continue to study as we try to learn more about this patient population. But let's look at the good side of things, because there is a really good side of things with IUDs and girls and women with heavy menstrual bleeding, and that is that we do show improvements. And I talked about this a little bit in the earlier slides, but there have been the studies that I've already mentioned, as well as a couple of others that are single institution studies that have really shown that in women with bleeding disorders, the use of the progesterone-based intrauterine devices can improve both their PBAC or pictorial bleeding assessment chart scores, as well as their hemoglobins. And that also is associated with an improvement in their quality of life. And so I think that it's really important that we remember how much heavy menstrual bleeding can really affect our patients, and how helping them to control that can really be really instrumental in their everyday life and their psyche and their moods. And a lot of these girls are adolescent females. And so for those of us who lived through that, it can be difficult with or without heavy menstrual bleeding. So just a really important bullet that I feel really strongly about. Finally, really just to conclude with a question. So how effective and safe is the use of the levonorgestrel releasing intrauterine system in adolescents with heavy menstrual bleeding and bleeding disorders? And this is something that our research group is really looking to, trying to gain additional insight and understanding of some of these concerns that I've mentioned in the last couple of slides, and also trying to understand the optimal way that we can introduce this device to our patients and implement this device use in our patients. And I'd like to thank Yemi for her lovely description of how we can think about this device and how we can think about it in our patients and use it. And with that, I'll leave you guys with this question and the hope that other people are interested in learning more about this topic like we are.
All right. I hope everybody can hear me. This is Claudia again. This is our time for Q&A, and we are open to questions. We already have some questions coming in, so I'm going to start with some of those. That was a really excellent review. Thank you to both Dr. Wheeler and Dr. Adeyemi. So we have a couple questions here that we can start with, and the first one is a really frequent question or situation I find we encounter, which came from Trin Nguyen. The question is, what do you say to someone, a patient or a parent, who does not believe in hormonal control for heavy menstrual bleeding? How successful have you been at convincing them, or do you just use Listita and hope that's enough? So I think we probably all three have experiences addressing this this situation, and I think both of our panelists, our speakers, can speak to this from their different discipline perspectives. So let's see. Do you want to start, Yemi, with your insight about that in terms of a patient who has concerns about using hormones for bleeding control?
Sure, happy to. So, the first thing I let the patient and parent know is that I am willing to work with that. And I typically will ask, well, why is it that you are not comfortable with hormonal therapy? Because sometimes the concern is something that I can address, and with understanding, they become more willing to give it a try. And then I look at the objective data that I have. How severe is the bleeding? And looking at the hemoglobin level, is it 5? Because we don't have much reserve if that's the case, versus if they're complaining of heavy menstrual bleeding, but their hemoglobin is, 13. I do mention antifibrinolytics in my counseling, and especially, we go into it in a little bit more detail with parents or patients who have concerns about hormones. And then I'm willing to negotiate, again, just based on the clinical picture. And I might say, well, let's start off with antifibrinolytics. Let's do a close follow-up. And when you come back, if that's not really working, then we might think about adding hormones. And so I think some negotiation goes into play.
Thank you. Dr. Wheeler, do you have anything that you'd like to add to that?
The only thing I would add, and I take actually almost an identical approach to Dr. Adeyemi, is sometimes I point out that oral Provera does not provide birth control benefits. So a lot of times the parents of my patients are worried about hormones because it's birth control, and some of the points that were mentioned in the talk. But oral Provera doesn't provide reliable birth control, and so sometimes they'll accept that as an option. And between that and Listita, I often can sort of try one or both of those in, either in parallel or in sequence, and if neither of those work, then sometimes they're a little bit more open to the other hormonal options that do have a birth control benefit on top of the menstrual bleeding benefit.
Thanks. Yeah, and I would just add a couple things to both of those. The first is that when I have patients or parents who say something to that effect, I don't believe in hormones for medical uses, I will often ask them what are the things that influence that belief, or what are the causes for them worrying, or try to get a little bit more qualitative information from them. And often patients or parents will say, I just don't believe in that. They don't offer a lot. And sometimes I think it's their concerns about insulting us or feeling like they're being oppositional. So I will very proactively bring up some of the concerns that Dr. Adeyemi had on her slides. So I'll say, is it okay with you if I talk about some of the concerns that other patients of mine have had? Many people are concerned that this will affect future fertility. Many people are concerned this will influence their adolescent sexual activity. Many people are concerned this may cause cancer, and I will bring up the things that are most frequently on people's mind and go through them one by one. And that often sort of just makes the conversation more open and makes people feel like they can actually talk about their concerns if I didn't already mention them. And the other thing I would just bring up quickly is that, as many of us know, sort of issues of reproductive justice have been coming up a lot in current news and historically. And I think for some of our patients, they are mistrustful about different reproductive technologies and hormonal agents that have been used, sometimes without good informed consent, in different communities in our country. So I may also bring that up and say, I know there's a lot of things in history that make people mistrustful of these things that doctors have been involved in, and I want to acknowledge that I know, that I'm aware about those things, and do you have any concerns there that we could talk about? Because I offer these methods to all of my patients, regardless of who they are, because I think they will help. So I think that can also go a long way. We have another question from my colleague from CHLA, Michelle Rowland, who asks that we please define the use of hemostatic prophylaxis. So maybe both of you could quickly in our last minute say what are some, even though we don't really have guidelines for this, what are some recommended pre-procedural, practices around medication? If someone is actively anticoagulated, do you tell them to stop for the day? And if they have a bleeding disorder, what hemostatic medications would you use?
Sure. Allison, I'll let you go on this one.
Yeah, I think that there's a lot of variability here, and depending on the bleeding disorder, to speak to a couple of the other questions as well, for patients with von Willebrand disease or factor VIII deficiency, I think people utilize Stymate or DDABP, sometimes just using antifibrinolytics in association with the procedure, or sometimes if somebody truly has a more significant factor deficiency or a factor IX deficiency, thinking about direct factor replacement. I personally approach this a little bit with sort of practicality, as well as also with how much that patient does bleed and how aggressive their heavy menstrual bleeding is, and also sometimes the anxiety of the patient. So I'm more likely to do Stymate when it was available before the recall, or antifibrinolytics a little bit more aggressively in maybe a younger girl who's had a really hard emotional time with her heavy menstrual bleeding. And so for me, there's a lot of variability. And I think that's something that we really definitely need to know more about. But from our survey, it also showed, I think, that there's variability among pretty much all providers in this regard.
Thank you. We had a couple other questions, similar questions, so I hope that Dr. Wheeler answered them. And the truth is we don't have good guidelines for this, so we are working on that. So I know we're at time. We have our panelists have a couple more minutes to answer questions. So those of you who can stay on are welcome to. And We have a few more questions in the chat that I'm going to sort through. I think one question here that Dr. Adeyemi maybe can answer is, why does it take up to 3 months to see improvement? What is happening during this time? And I would add on to that, if you want to offer your suggestions about how to manage that breakthrough bleeding, because sometimes there is significant bleeding at the beginning after IUD placement, and it does distress patients sometimes. So if you could address maybe why it takes so long and what we can do about it.
Sure. So certainly there's some disruption of the, the endometrial lining that can occur with the placement of the IUD. The other thing that I think about is that, estrogen leads to thickening of your endometrium, and progesterones tend to stabilize. And so they work together physiologically. And when you have combined hormonal contraceptives, you also have that advantage. Now, progestin only, when you have just progestin and no estrogen, this balance is lost. And all progestins can cause irregular bleeding. But the other thing that all progestins can do is cause atrophy of that endometrial lining over time. And so if you don't really have an endometrial lining, then there really isn't anything to slough off or to bleed. And so that can take a little bit of time to help. And in terms of the complaints that we get, what I use at times, if the patient is able to tolerate estrogen with no contraindications, I might give them a pack of pills and ask them to use the active pills for about 3 weeks or so. Sometimes using the progestin medication, Agestin, can also be helpful. A little bit of it is converted to estrogen and can help combat that.
Wonderful, thank you. And then we had a question about the insertion procedure, about what is it about the insertion procedure that would necessitate hemostatic medication treatment, because the video did not indicate why it would cause bleeding. So I know Dr. Adeyemi can add to this, but I don't think that the insertion video showed the use of the tenaculum, which is an instrument that we put on the cervix for stabilization. And that can cause some mucosal bleeding. And then additionally, sometimes just with the insertion itself, correct me if I'm wrong, Dr. Adeyemi, there can be some uterine bleeding coming through the cervix as well.
Yes, that's exactly true. And so I would say the most traumatic part of placing it is that tenaculum, which you have mentioned, Claudia. And in our case, when we have patients with really severe bleeding disorders, we sometimes will actually use a stitch to act as the tenaculum and to stabilize that the cervix and straighten the uterus. I know this is not something that is done across the board, but the advantage for that in our practice is that after you place the IUD, then instead of just taking up the tenaculum, which now has the puncture sites in the cervix, you can actually just tie down the suture, and that would provide some hemostasis as well.
Right, and some people I know also will use a ring forceps instead of a tenaculum for that same reason. It has a different traumatic effect on the cervix, but can avoid those punctures. So I think we are at time. Thank you everyone for your participation. You will get a post survey from the foundation through GoTo meetings and GoToWebinar, and the presentation will be loaded to the foundation website for anybody if you had any trouble with your video or audio and you would like to see it or recommend that anybody else look at it. So thank you so much everybody for attending. Have a wonderful rest of your day and weekend.
Thank you.